I think quality of life should be the prime drive. This is a palliative setting. These patients are not going to be cured of their cancer for the most. I mean, there are a small subset of patients with just isolated liver metastatic disease that could potentially be cured or live disease-free for prolonged periods of time without cancer. But the overwhelming majority of these patients, 90 to 95%, will never be cured. So your primary goal should be palliation. And essentially, quality of life is an important piece of the equation. There's also the cost issue as well, of course, which we call now financial toxicity. But the quality of life is primarily important in addition to the prolongation of survival. So both regimens do prolong survival, and both have different toxicities as we've discussed. Some are more or less acceptable depending on the patient's preference. So I think it is very important to have a very frank discussion with the patients about those different regimens, about their differential toxicities, more diarrhea, more neurotoxicity, more neutropenia, etc., more fatigue on the long run. The other thing I think that's very important to keep in mind is that for most of these regimens, continuing with the chemotherapy combination beyond 4 to 6 months is really not indicated anymore. We have a lot of data that suggests that we can go into a maintenance phase, meaning you drop the irinotecan or the oxaliplatin after 4 to 5 to 6 months, and patients will continue on 5-fluorouracil, so 5-FU, or capecitabine plus bevacizumab, and their outcomes seem to be very similar. So you really don't need to keep on beating up on patients because you add the risk of toxicities. Sometimes patients prefer to take what we call chemo holidays. Now, chemo holidays, meaning you stop all chemotherapy after 4 to 6 months of treatment, have been looked at in a number of studies, and what they would suggest are that you shorten the progression-free survival if you don't maintain chemo. However, it doesn't seem to actually affect survival significantly. In other words, it is possible that you could essentially provide certain patients, let's say those that have a complete response or those that have a very solid response and no evidence of growth, and they request a holiday. They want to travel, they want to do something else. They just don't want to deal with chemotherapy. I think it's acceptable to give patients holidays in a palliative setting.